thank you for Professor Sharma and also Professor Papadakis, who were my supervisors on this topic that I spent 3 years on. So it's a close thing to my heart, essentially. So I'm just briefly going to quickly go through the athlete's heart and then go through the process of this conundrum. As you know, an athlete is not like a normal person, a sedentary person. They want to increase their oxygen demand because of the amount of exercise that they're doing. So they increase their cardiac output, increase their stroke volume, we know this, and they increase their systolic blood pressure as they're exercising. And we end up having a reduced peripheral resistance just to provide all of that output, essentially. We often find that they can be profoundly bradycardic, which we're quite used to. They markedly have enlarged chamber sizes. They can increase their wall thickness, and there's sometimes evidence of LV trabeculation. Now, what we do know about athletes and dilated LVs is that up to 50% of endurance athletes can have a dilated chamber. As you can see from the graph, males tend to have a more larger chamber than the females. We used the BSc cutoff in our study this year, and it was 51 for females and 56 for males millimeters. We also see left atrial dimensions get increased. Again, it's proportionally more males than females. And we will see the wall thickness is often around about 10 to 11 millimeters. They do increase, but this is the dilated heart. It doesn't thin like a dilated cardiomyopathy. Notoriously, it's endurance athletes that we've looked at to see the LV dimensions that have increased. And when they looked at the Tour de France group, 51% revealed a cavity size that was classed as quite significantly severely dilated of 60 millimeters. And about 11% of these showed a reduction in ejection fraction. And this is where our conundrum begins, because if you've got a dilated LV and a reduced ejection fraction, how can we now distinguish this from a cardiomyopathy? Also, as you can see, cycling, rowing, canoeing, and swimming are the top ones. I just want to point out that now you have to be aware that people are starting to do cross training. They're starting to do activities in their jobs. We had dancers, or they had tree climbers and things. That was in my study. So you have to take a very good history. And actually, people are doing mixed sports, or they're swapping sports in their 20s and 30s. What influences the big heart, and that what you have to be aware of? 50% of this is associated with body surface area, so you have to take that into account. 4% will be associated with age. 7% is gender associated, and it's more often seen in males. 14% is the type of sport, so make sure you take a good, accurate history. And about 25% will be unexplained of why they've actually dilated their cavity. Now, the difference with dilated cardiomyopathy is that that's a primary heart muscle condition. It's an increase in chamber size, but thinning of the muscle wall, and with a reduction in systolic function. And you have to make sure this is not down to a loading pressure such as valvular heart disease. It's not down to ischemic heart disease or any other cause. So that has to be excluded. And that's what we did when we enrolled people in our study. So the big lazy heart and the conundrum. Why are we concerned? So healthy athletes, it's often thought of as benign adaptation. It will often reverse with detraining, but as you heard from Prof. Sharma, we don't like athletes to detrain because it may impact on their career. And there's no current data or significant data to suggest that this has a long-term detrimental consequence to their life or cardiac outcome, essentially. That's very different to a dilated cardiomyopathy, and especially early dilated cardiomyopathy, which sometimes is asymptomatic or is undiagnosed. They have an increased risk of sudden death, increased risk of arrhythmias, heart failure, which can be progressive, and it can have a mortality rate 10 to 40%, dependent on how much you've titrated their medications or if they've ever been initiated on medications. And it's really important to actually diagnose this because we've got such good prognostic medications that actually can increase their life expectancy. So a few years ago, we did a pilot study which helped with this conundrum, which involved blood testing, ECGs, Holter monitoring, exercise echocardiogram, and cardiac MRI. And as you can see, we had these differences between the two. And we said, if you put an athlete through these series of tests, then it may help us with their outcome of finding out what they have. The issue is not all dilated cardiomyopathy will have left bundle branch block or frequent VEs or T-wave inversion. Often their Holter monitors may not show non-sustained in the early stages, and exercise echocardiogram, depending on which center you're at, is that enough, essentially? And the presence of LGE, scar. Now, we all know early DCM doesn't always show scar when you do a cardiac MRI. So this is why you need a series of tests, because it will help you solve the conundrum rather than rely on one single one. So we did a bigger study. So for the past, well, over 2 years, between 2021 and 2023, we recruited 180 athletic individuals, and we defined that by they had to be exercising more than 4 hours per week for a long period of time. So it had to be 3 to 6 months, and they had to have already shown LV dilatation on imaging. So confirmed some sort of query adaptation. Now, we had 3 cohorts. Confirmed DCMs that remained athletic, are healthy athletes, which we had followed up or were in our database and had been surveillance for over 5 years, and we knew nothing had changed with them. And we had our grey zone athletes who had the sluggish, lazy heart, essentially at rest. And they all went through ECG, blood tests, echocardiograms, stress echo, CPET, and CMRs. Now, I'm going to focus on stress echocardiogram, because what we did this time round, and the other data is yet to be released and fully analysed, but our preliminary data on 143 of these athletes, 47 of them were DCM, 44 normal athletes, and 52 grey zone athletes, went through submaximal testing plus maximal. Now, we defined submaximal as our 80% of their maximum heart rate, and their peak exercise was classified 90% to 100% of their maximum heart rate. You have to be aware when you send someone for a stress echo and you put them on an ischemic stress echo list, the target heart rate is 85% to exclude coronary artery disease. So our athletes had to go through maximum testing to see if there was any difference. So this is why it's really important to do it at a sports center or someone that has an athletic protocol. So the top one is our confirmed athlete with DCM, and hopefully this will all play. And the bottom is our healthy athlete. So if we go systematically, you've got rest, 80%, and peak. So what we see with our healthy athletes is that the cavity size will continue to get smaller and smaller, and also almost have complete obliteration at peak exercise. And what we were looking for was to see that either it carried on increasing between our 80% zone and our peak, or it remained the same. If you look at the top column, you can see that there's actually not much difference between 80% and peak in our DCM stress echo. It doesn't seem to pick up visually. We did live studies and looked at them visually, but we also did ejection fraction biplanes on our patients. So sorry, they did have the results of it, but it hasn't come up. So if you're used to looking at the stock market, this might be easy on your eyes, but if you're not, I'll have to explain it. So if you look at the bottom, these were all of our healthy athletes, so 43. If you look at our maximal biplane, which is the red marker, what you're wanting to see is that all of the red marks are above your blue zone. So the blue zone is your submaximal, so that's at 80%. So pretty much every athlete, so 97.7% of athletes had a higher peak ejection fraction compared to their 80% ejection fraction. Now, when we compare this to our DCM cohorts, actually the blue line is above the red line on most of them. So actually the DCM cohorts, they had a better ejection fraction at their 80% zone, and they all seem to have dropped their ejection fraction at their peak target heart rates. Only 4.7% of DCM patients were able to augment the increase. Then when we looked at our grey zone athletes, they were quite comparable with our healthy athletes. The mean ejection fraction increase from rest to peak was 20.2 compared to our healthy athletes. This was 4.7% in our DCM. In 90.4% of grey zones were able to augment that 10% increase that we had already defined a few years ago from rest to peak. but they were also able to augment an increase from 80% to peak zone. Now, I just want to highlight that before we did this study and other departments that do stress echoes, the intravariability can be between 10 to 15% in biplane ejection fraction. We made sure that our intervariability was between 1 and 1.5%. So we had to make sure there was a standardized protocol. We had an agreement amongst us when we was doing these biplanes because it matters at the end stages. So just quickly on CMR role, because we are evaluating our CMR data as well, what we do know is that when we're visually looking and when we're doing our volume analysis, we're looking for symmetrical increase in chamber sizes. We're trying to ensure that there's no evidence of regional wall motion abnormality, and we look at their stroke volume because in athletes that don't have dilated cardiomyopathy, they will often have a higher stroke volume, even when you BSA it compared to our DCM cohort. The typical scar pattern that you'll see in DCM is mid-wall scar, often in the septum or the infralateral wall. This is not well defined in athletes, but obviously no one's compared dilated normal, dilated low ejection fraction, and DCM that are athletic, and that's what we're doing now. So if you've looked visually at all of these, which is the gray zone DCM, other than the fact that its structure looks slightly different, and that's more to do with body habitus, the contraction on the healthy athlete, there's more of a squeeze. So that's a bit obvious that this looks like a healthy athlete with a normal ejection fraction. But when it becomes mildly impaired or low normal, you can't really tell much difference between a gray zone and an athletic DCM. So that's why we need to look more into this. And we're looking into scar patterns, the strain on MRI, and also a bit of exercise CMR, which has already been done before, but not on such a large cohort. So this was on a small study that consisted of 24 patients, and they didn't compare athletic DCMs. They compared healthy endurance athletes against DCM and endurance athletes which had confirmed subepicardial scar. So they weren't confirmed to all have dilated LVs. So I truly believe that's a completely different cohort and they need to be compared. And that's what we are doing here at St. George's. So the pilot study had shown 50% of DCM showed scar compared to 0% of grey zone athletes. But we're analysing our 180 patients, and that's going to be what we're going to focus on this year, essentially. So the take-home messages when you're looking at these are basically healthy athletes, and the majority of grey zone athletes will increase their ejection fraction by 10% from rest to peak. And they should also augment their ejection fraction between the 80% zone to their peak zone. And healthy athletes and majority of grey zone athletes will have a positive, like I said, submaximal test compared to the DCM, which often won't have that augmentation, essentially. And make sure that when you are looking at when they confirm that there's a peak adequate test, what was their heart rate that they achieved when this is done.